us today. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center, otherwise known as MCTAC team. And I am joined today by a number of partners and colleagues from the Office of Mental Health who will be running through some content for today's webinar. I want to thank you all for joining. I know there's a lot going on in the world today, and we're just appreciative you're able to dedicate an hour to this really important information. Just a few logistics about today. We are recording this webinar, so the slides and the recording are going to be available to you afterwards, which is great news. You can share it amongst your colleagues if you'd like. The other thing is we are dedicating time at the end to take questions. So if you have a question throughout the webinar, please don't hesitate. Please just chat it in. If you could chat it in to all panelists, you'll see on the right-hand side of your screen, there's a chat box functionality. And if you see the word chat, there's a little arrow next to it. You should be able to then view the entire chat screen. And if you could just select chat to all panelists, that way we can all see the questions. MCTAC is taking notes on, all the questions that come in, and we are going to try and organize them. I know that the state's going to do their best today to answer the questions as best they can, but just given that information is coming out and being updated regularly, there might be some questions we're not able to answer today. So please chat in your questions. We'll collect all of them. And again, if the state's not able to answer the questions today, we will do our best to answer them in the time that we're able to. So with that, I think I want to just thank again everyone for joining and our OMH partners, and ask Emil to take it away.
Hi, this is Emil Slane, Deputy Commissioner and Chief Fiscal Officer for OMH. Good afternoon, everyone. As Meg said, this is about giving additional guidance on the state aid funding flexibility memo that we issued last week. We wanted to have a webinar to present how OMH envisions this working and get you more details on that so you can navigate it, as well as give you updates in some of the other areas like Medicaid flexibility. So we're going to just walk through some of the guidance that's out there and answer questions and continue to update it on our website. So our goal is to provide state aid flexibility to support community mental health providers during this emergency period. We want to make sure that this flexibility helps providers utilize state aid resources to address any unbudgeted, unplanned costs. We're fully committed to partnering with the providers, on this flexibility to address some of these challenges during this emergency period. And I think our shared goal really is to preserve access and continuity of care to every extent possible, and to recognize some of these COVID expenses to preserve operations and community infrastructure. And we're going to talk in more detail of that. So we're first going to start talking about state aid contract flexibility. This particular webinar is with all the direct contract providers that OMH holds the contract instrument. So what you'll hear probably is more questions geared towards OMH direct contracts, and OMH would be the entity that you're working with to institute that flexibility on your instruments. What we want to emphasize here is that OMH will approve waivers to any state aid contract requirements. If you contract with the Office of Mental Health, you know that we have something called spending plan guidelines, and we also have different rules in terms of programs and funding codes. And what we're saying here is we would entertain waivers to any of those requirements to allow funds to interchange between programs. And we're going to go into the process here and give you some more examples and details on that. We recognize that during this COVID response and emergency that providers need flexibility in the use of resources to address some unplanned costs. In the guidance we issued, we referenced some examples of flexibility and waivers that can be requested. We do not view this as a comprehensive list, but as you can see that we do reference occupancy standards for residential programs, service utilization standards for care management programs, metrics and standards that may be cited in your work plans We view this flexibility as enabling providers to get on record with OMH where they may not be able to meet those standards, and that funds are needed to address other costs that they're incurring related to this emergency. That also extends to interchange of flexibility between programs and funds, interchange flexibility between budget categories. We will entertain other requests not listed in the examples, and we are going to give you a little bit more insight into what we're hearing and seeing and share with the community. But whether or not your question is answered today, if you want to submit them in writing, what we're going to be doing is updating a frequently asked questions document following the webinar and following any updates to this guidance. So that is a resource for the providers who are navigating these circumstances, and we're going to use that FAQ as kind of a governing document for the flexibility. But we'll talk a little bit about the waiver submissions. The flexibility that we're applying here applies to the 2019-20 fiscal period for New York City, the 2020 fiscal period for upstate, if you have a contract that's governed along that framework. Our general principle is that OMH is expecting that providers are following the OMH and state and county department guidance related to COVID. We want to make sure that providers are educated and supported on the appropriate public health responses based on science. An example of one area is OMH just issued guidance on residential programs and infection control information on that, and we'll be conducting guidance on that. As I stated when we opened, our real shared goal here is to preserve access and continuity of care and to use this flexibility to address some of the COVID expenses and preservation of infrastructure. So part of this response, and we listed this in the guidance, may involve a provider temporarily shifting staffing resources from a lower priority program that may have closed during this period to a program requiring additional resources. And we believe that that is a good example and logical response of the intent of the flexibility that we're offering here during this period. I'm going to talk a little bit about process and mechanics. Our goal is to support providers navigating this in a timely manner. When a specific request for flexibility and assistance is known, the providers can submit an email to the field office, and all requests that you're submitting should include details so that OMH can act on this quickly. We would like the detail to include the purpose of the request, the type of flexibility needed, the specifics of the funding allocation changes, and the relation of the request to the COVID response and the broader agency operations relating to it. You have OMH's commitment that we will review and respond with approval or request for specific additional information quickly. Given the urgent nature of all the work that's going on, our goal is to try to turn this around within one business day. So we're committed to working on this and making this among the highest priority. The key in all this is the detail and the request of flexibility. And OMH wants to make sure that we have that information and as you move forward so that we can ensure that any approved requests will be fully honored in the closeout process and funds will be retained. As we update our FAQ information, this will also be a helpful resource to the counties that administer contracts as well. So I'm going to talk a little bit about some examples of flexibility, and some of these are things that we're starting to get from the LGUs and the providers. So we wanted to include them in the webinar. We have gotten some requests for LGUs to reallocate funds that were available in the state aid letter between programs or fund codes to address COVID needs. We've been asked for some contract flexibility to reassign staff and funding between programs to maintain essential operations. The example that I was talking about before, we talked about the additional COVID-19 infection control guidance for residential programs and how that may require some additional cleaning or supplies. this flexibility is intended to help support that in any way possible. And we've also gotten provider examples of additional overtime or personal expenses to address the COVID costs as you manage your community programs and operations. And then another area that we've clearly seen is one-time cost for providers on continuity of care plans, setting up telehealth. All requests really must be within the current available state aid contracts and state aid letter allocations that are out there. We want to make sure this flexibility gives you full access to it and enables you to use these resources. One of the things that we want to highlight here is that if you also have Medicaid funded programs, that the state aid flexibility applies to these contracts that both OMH holds and the county holds. OMH has come out with guidance on telemental health. We've gotten a lot of feedback on this from providers. Many providers have been able to provide continuity of care for large portions of their caseloads, but we get the challenge here. The other thing that Gary Weisskopf is going to be giving an update on at the end of the presentation is talking about how the state has pending requests through an 1135 waiver to go as aggressive as possible on the front end to preserve Medicaid billing and revenue to support continuity of care in these programs. So we're going to go into more detail on the Medicaid side. Really the presentation and conversation here is on the state aid flexibility that we want to make available to the provider community during this extraordinary period. I'm going to pass it over to April, who's going to talk a little bit about some of the other actions OMH is taking.
Thanks, Emil. This is April Wojtkiewicz. I'm the Director of Community Budget and Financial Management here at the Office of Mental Health. As Emil mentioned, we have issued some guidance in the last week regarding various deadlines and actions that we've taken, so please do take the time to check out our webpage. We do have the links available for you on the presentation. The first thing you probably saw was our CFR deadline. OMH issued guidance last week indicating that for calendar year filers, we have extended the submission deadline to August 1st. That was issued last week on the 18th. We do anticipate continuing to revisit that decision based on how things continue to evolve, but at the moment we are extending until August 1st. And we have also, for those who we've lifted sanctions related to failure to file the CFR for the moment. They're on hold and suspended for a period of a couple of months for those who are behind. We have issued separate guidance to those individual providers, but do know that that is happening at the moment. In terms of contracts, all quarterly payments went out, and we did not withhold any funding from those payments this time around. We actually ended up, you may have gotten 2 payments because we had initially put in to withhold funds, and then given the circumstances of what's evolved in the last 2 weeks, we rescinded those recoupments. So what we've done is potentially sent 2 payments to you, which should equal your full April quarter payment. And those, if they have not been received in your bank account, they should be shortly. Those payments are continuing to process through the statewide treasury and are happening now. And there should be no delay in payments moving forward. We've taken steps to ensure that we have staff available and processing both payments as well as contract amendments and renewals and modifications. We know that many of those mods and amendments result in more funding going to you, the provider, so we are ensuring that those things continue to move. Please, in terms of technical assistance, do not hesitate to reach out to my staff for any kind of assistance you need, or to the field offices. We all stand ready to help you. We know this is tough, and we know that we've got to give you as much support as we can. But since many of you are operating in the Grants Gateway, which is fully functional, and my staff do have remote access to it, we are able to move documents. So please don't slow down sending us stuff if you can avoid it. We are able to move things, and the minute things get approved and executed, we are queuing up payments to go out related to those changes on your contracts. So please, please, if you need help, let us know. In terms of closeouts, you probably also read in our guidance that we suspended the issuance of state aid closeouts. We will continue to process them, but we will not burden you with answering to them, and we'll hold on to those for an indefinite period of time. We'll continue to reevaluate, but for the moment, we are going to suspend issuing state aid closeouts for any providers. In terms of audits, all audits that are currently pending will be given extensions on responses that you've been asked to provide, and any audits currently underway are temporarily suspended. New audits and opening conferences will be postponed until further notice, and our audit team, the OMH audit team, will engage you at such time when we do lift the suspension. So know that we will not be asking you any more details regarding any audits that are currently underway, and will not be initiating new audits at this time. And I'm going to flip it back to Emil.
Thank you, April. We also want to, and we mentioned this in the guidance, we're advising providers to track any and all COVID-related expenses. We think it's important in this situation. A FEMA emergency has been declared. It may provide some opportunity for relief down the road, similar to a Hurricane Sandy, where we were able to recoup some expenses on the back end. If there are any extraordinary situations, and we've experienced similar challenges with Hurricane Sandy, where we had to relocate residences. We know that this is a very different situation, but if there are extraordinary expense situations where you need to reach out to OMH for technical assistance on how to navigate it, we encourage you to do that. We will partner with with our direct contract providers, as we deal with these challenges. I think the other key thing here is, and I'm gonna turn it over to Gary in a second to talk about Medicaid and flexibility. The key thing is we are pursuing additional flexibility on the Medicaid side, which we hope will help to mitigate the revenue challenges and the continuity of care. So I'm going to turn it over to Gary to give an update on that.
Thank you, Emil. This is Gary. Are we on the right? Okay. So we've done a lot very quickly to try and provide flexibility to providers, because we really want two things. We want people to continue to receive services, and we want providers to be able to remain open and take clients. This is really, really important for everybody. So we have expanded telephonic access to care. So now all providers, as long as it's appropriate, with some limitations in the residential area, can use telephonic and televideo in order to remain connected to individuals. Remember, this is not a new service. It's the ability to deliver the services that we currently have through a means of telephonic. So these will count as face-to-face contacts, and they are reimbursable. There's guidance out and a number of frequently asked questions on the OMH website. I strongly encourage people to look at that. There's a link that will be coming up, and when this is sent out, check out the frequently asked questions, because it's changing as we answer more and more questions and get answers to more and more questions. We're putting them up on the OMH website. But telephonic, telephone and video are both allowed. All that's required for OMH is an attestation form for the agency that gets sent in to Amy Smith, and that's it. You're good to go right from there. You also need to bill using the GT 95 modifiers, and we're going to be putting up more information shortly on which procedure codes need which modifier. That's so that we can track this as we go forward. Please keep in mind, DOH has put out comprehensive telehealth guidance, and for billing in Medicaid, this guidance says that there's specific OMH, OASIS, and OPW guidance. So when you see our guidance and it's in conflict with what's in the DOH guidance, our guidance at OMH supersedes for the programs that are covered by that guidance, and they're all listed there. You need to follow what it is that we're saying. So it's just important to keep that in mind. We're also working on other flexibilities, such as staffing flexibility, allowing verbal consent from patients for care both through telehealth and also the treatment plans. Billing flexibilities, we are working on this now. We're hoping to get federal approval to be able to modify the time required for different services going forward, so that we recognize it's very hard to stay on the phone for 45 minutes with an individual. Also, if you're doing group sessions, that can be really tricky. And we know particularly for programs that are day programs or that have, reimbursement that's more complicated, it can be very difficult. We want to try and streamline this. So I'm going to talk in a second, if we go to the next slide, about the 1135 waiver that the state has put forth to CMS. The 1135 waiver is available in the event of a disaster. CMS and the president have declared a disaster, so the 1135 waiver process can begin. The state has asked for very, very broad authority in a number of areas, which I'll go over in a minute. From CMS, it's not clear that we'll get it. We hope that we get it. We will know hopefully more in the next few days. Some of the things that we're asking for is the ability for verbal authorizations for services, something we've already done anyway. And CMS has said, just do what you have to do and we'll clean this up after. Clinic offsite coding changes so that we can do shorter amounts of times with the same CPT codes. Build broad flexibility in how we can target payments to providers and pass through money to providers, and really change how we pay providers so that we can ensure that we can get as much of the money that's currently in the managed care plans and other places that's dedicated for behavioral health, so we can get it out to the providers and keep them afloat. So there'll be more on that as we develop it, and we know that we have federal authority to do it. IMD waivers, so that people coming out of the Article 28s who come into our state hospitals and other residential INDs we can still get reimbursement for serving those individuals. Reduced contact standards. We're looking at reducing the number of times that an individual has to be seen in a month in order to get paid for some of those programs. And then flexibility on provider credentialing, utilization management, things like that. So they're really, this 1135, if it were to get approved the way it is, would give us broad flexibility to make a lot of rapid changes in the way reimbursement is done. We're trying to see if we get that authority. We want to keep the money flowing through the same procedure codes and the same billing methodologies that we currently have to reduce as much as possible the need to reprogram any billing system. So there'll be a lot more to come in the near future once we have more information from the federal government. We can go to the next slide. Again, this is really important. The OMH website has a lot of guidance, and we're continually putting out more guidance, particularly the frequently asked questions. A lot of answers already out there in frequently asked questions, and more are coming every day. So that's all I have. Thank you.
All right, thank you so much, Gary and Emil and April. What I'm going to just remind folks of is that we are taking questions and asking you to chat them in. So I know we've collected some. I know we've got a little bit of time left, actually. So if you have a question that you'd like to be answered, or our OMH partners will try and answer today, please don't hesitate, chat that in. I'm going to start to read from our collected questions list. And OMH partners, if you are unable to answer, just let us know and we can just move right along to the next one. Like I said, we're collecting every question that's chatted in. So our first question is, what kind of documentation will be required for a staff member purchasing minutes for a client on the staff member's personal credit card to be reimbursed with state funds?
I think the intent here is flexibility with the state aids and the contracts that are out here. We would advise that you follow the guidelines that are out there currently, and to the extent that that slows you down in any way, to reach out to OMH. So if it is an expense that can be charged against your contract, or if you need some flexibility for the state to consider that expense, you should contact OMH. Again, this webinar, the invite list was all direct contracts that OMH actually administers the instrument, and you could reach out directly to the field office and to community budget to get a response to any request for flexibility.
Thanks, Emil. Let's see here, our next question. Let's see, so I guess the next question is really about what is available to cover, are the funds that are available, are they allowable to cover extraordinary expenses such as technology and overtime, or is this a one-time cost for telehealth setup?
We are basically acknowledging that if there are funds available on your instrument that you otherwise would have underspent, that if you incurred expenses in community mental health programs related to setting up telehealth or paying for overtime costs, that OMH would allow for flexibility within programs and funding codes to address that. So we're just asking that you give us some insight into the flexibility that you need, and then you will get a response from OMH so that you can act quickly on this, because we know that all providers have continuity of care plans, and that even in the past week we've all been rapidly responding to the emergency. So if you could specify the exact flexibility you want on the instruments that you have, OMH will respond to it and act on it.
Okay, so I think we're going to get some specific questions about this now, Emil, actually. So another person is asking how provider agencies would then allocate funds from service contracts to comply with the state program 9 bill, where quarantined COVID-19 related paid sick time is not taken from their accrued time off. And again, I don't know if that's something we can address right now, but that is a question that just came in, that just popped in.
I think that's a great question for you guys. You submitted in writing. We'll put more details in the facts on that. And if you could,
Sure.
I think your name, we'll have your name, and if we need more details on the specific situation, we will reach out to you and then post it in all the FAQs so that everyone in the provider community can benefit from the response. Great.
Thanks, Emil. And for the person that chatted that in, we do have your name, so don't worry. We'll be making sure once we get a response that you get that info. And for everyone who's chatting in questions, we have your name associated with the question. Let's see here. Let's see. Okay, so is there flexibility between state aid contracts if one is direct with OMH and the other flows through county contracting processes?
OMH will consider interchange flexibility between the instruments. I think there is a little added complexity about working out how the mechanics would work. What we're advising providers is if they have an instrument with the county and they need flexibility, they should pursue that flexibility with the county. We did training with the LGUs. The LGUs understand the intent behind OMH's guidance and flexibility. They will be trying to fulfill that on their end. OMH on the direct contract end will be dealing with any flexibility you need in your instruments. But to the extent that your plan involves a broader flexibility between instruments, we will explore how to support that. I would get on record with the with the details of the plan and the flexibility you need.
And I think there was just a follow-up to that I just lost really quickly. So just as a part 2 to that question, will the reviews be done in 2020 for contract renewals beginning in 2021? So that was just the second part of that question.
I'm sorry, can you read that again, Meg?
Yeah, can you read that?
Yeah. So it was just the second part of that first question I read. Will reviews be done in 2020 for contract renewals beginning in 2021?
Oh, will site reviews and contract, okay,
Yeah.
I think this is relating to renewal of contract, sorry. Took me a minute.
It's okay, all good.
I mean, we will continue doing what needs to be done. I think given the current circumstances, we're not starting those reviews yet. They won't be started. They wouldn't need to be started until later this year. Certainly, we'll have to take into consideration everything that's going on. we'll get back to you with a more detailed answer. I think it's all a little unknown right now for us, but we are trying to continue with some business as usual in terms of making sure that instruments are renewed and things continue, moving forward.
Great, thank you. So our next question, again, about flexibility and funding. So is there flexibility to reallocate funds between direct state aid contracts within the same provider?
Yeah, I think similar to the question about county administered contracts and OMH administered contracts, if you have two instruments that OMH manages and you need flexibility between those instruments, OMH will consider such requests and flexibility. I just think we need the details of what you're trying to achieve and what you're trying to address on the ground so that OMH can honor that on the back end. We want to make sure that any commitments to flexibility, when we close out these instruments, that it's fully honored in terms of the provider having their costs recognized and state aid funds being retained.
Got it. So it sounds like, Emil, what you're saying is the state is willing to be flexible, but please communicate what you're asking for sooner rather than later about this.
That's correct. As soon as you have the details, obviously this is going to keep evolving. If you don't have specific requests at this time, you understand what the state's intent is here, that we want to work with you as a partner and we want to support this extraordinary challenge we have. So I wouldn't rush and force a request if you don't have specific details yet. But as you get those details, if you could come to us, we will get you an answer quickly. And as we act on such requests, we will, in the FAQs, put down examples of things we're allowing, because OMH always tries to honor such policy and approaches systemically. So if you can get us those details, you have our commitment to review them and act on them in a timely manner.
Thanks, Emil. So I'm thankful everyone keep chatting your questions in. I'm just trying to read through and find questions that we haven't started to address yet, but a lot of these questions are somewhat similar but have tiny nuances. So forgive me if they do sound a little repetitive, but I just think if we have the time, we should try and address as many as we can. So we have another question that says, can we apply for a waiver to move staff from one program to another under our contract with the LGU under the SAL?
Obviously, we don't know all the specific references there, but I think we did address that in some of the responses to the questions about between instruments at the county level, state level. I think the key is understanding, what the agency is dealing with and the type of flexibility they need so that we can navigate it and try to support it. I could tell you that, OMH wants you guys to focus on, the guidance and the logical response that's out there. We know that you have continuity of care plans and that you guys are navigating this at a quick pace as well. And we want to make sure we support that. So if you get us those details in a specific request, we can respond to the situation and then also update the FAQ and make sure that everyone benefits from that guidance.
Okay, thank you, Emil. Okay, so we have another question. Is there guidance on when the COVID-19 time off code is to be used, and how would providers be reimbursed for such costs if separate from the CFR?
Yeah, I think that's a question that we'll have to ponder a little bit, because I know we will have to talk about reporting requirements, which we'll probably issue some separate guidance. We've done similar things under Sandy, so I expect in the future there will be, but we'll certainly give more detail in a written response in the FAQs.
Thanks, April. I'll make sure that we take that question back. Okay, next. Will OMH allow so this is again more specific, but similar to what we've been discussing with flexibility. Will OMH allow flexibility with direct state contract funds used to offset loss of revenue in Article 31 clinics and PROS programs?
I think you saw in the presentation that we are pursuing maximum flexibility on the Medicaid end. So we have the telehealth out there, And then the next thing we're pursuing in the 1135 waiver is, implementing flexibility on some of the other requirements for outpatient programs. So we strongly encourage all the Medicaid programs to preserve continuity of care to every extent possible and to pursue billing to every extent possible. We do understand at the end of the line if there are Medicaid losses and programs are trying to navigate, preservation of staff and employees and payroll, to the extent that they're tied to the state instrument and there are funds available, we would consider that. But I think the key thing for us is that as the state continues to come out with more guidance on the Medicaid end, that those programs are really focused on preserving continuity of care and preserving any revenue possible consistent with the state's guidance. We think that's important for both the patients and also to ensure that those programs are, maximizing, funding here.
Got it. Thanks, Emil. Let's see. Someone is asking, so I guess there was mention of someone using their own credit card or cash to make a purchase, perhaps for minutes, I guess, on a phone. They may be stuck having to pay New York State sales tax. If we reimburse them, will we get reimbursed for sales tax?
I think the way to look at it, we know that what's going on is many providers are navigating setting up telehealth and continuity of care, and that may involve expenses related to laptops or phones for clients. And we view that those are expenses that we would consider under this extraordinary situation and circumstance. And to the extent anyone has questions on how to report them on CFR and ensuring that they're keeping proper documentation on it, they could contact us and we could help them on that end.
Okay, thank you. All right, and I'm sorry, I'm also trying to take down answers as well, so my apologies if I'm going a little slow. Let's see here. Can OMH undo takebacks from last year and hold off on them for the time being?
OMH is being clear that we are suspending all future closeouts and collections. They're being put on hold. We cannot undo prior period takebacks. Those are all dollars that, we've already recouped and the state has processed those. So what we are being clear in the guidance is that any future closeouts or takebacks are being temporarily put on hold, and we are being very clear that in the current fiscal periods during this emergency crisis, we're going to work to ensure flexibility and use of resources so that we can recognize as much of these expenses as possible.
Great, thank you. Let's see. All right, so here's a specific question about service. Could multiple 5-minute deliveries of service in apartment treatment be billable for Medicaid reimbursement in lieu of one of 15-minute face-to-face, which is normally required as part of the 1135?
Could you repeat it?
Sure. Yeah, so could multiple 5-minute deliveries of services in an apartment treatment be billable for Medicaid reimbursement in lieu of one 15-minute face-to-face, which is normally required? That would be as part of the 1135.
Yeah, we don't have an answer for that now. This is one of the things that is being discussed, is whether we can break up services in different ways. So hopefully we'll be able to get an answer out to people soon, and we'll know what federal authority we have to do things differently.
Okay, thanks, Gary. Let's see here. This may have partially been answered actually in the slides, but just to confirm and clarify, will providers need to request an extension from OMH regarding questions about OMH's preliminary review of prior CFRs? And would there be a 30-day extension available for the CFR?
Yeah, April, do you want to answer?
So as we indicated, sorry.
You go, April.
Okay. So as we indicated earlier, guidance was issued last week that we are extending the CFR deadline. I think, we are continuing to review CFRs. I don't think that there's an intent or expectation that you'll be able to respond to desk reviews at this time. So certainly that's an auto-generated letter. We'll work on fixing that. A lot of those were in process before these things started to happen. So we will look at changing the timelines and extending them for those that have already been issued. And we'll include that in the written response as well for the FAQs.
Thanks, April. Okay. This is again related to CFRs, and this may just be a clarifying question. How long will the lifted withholds due to the failure to submit CFRs last?
I'm sorry, can you say that again? Sorry.
Sure. How long will the lifted withholds due to failure to submit CFRs last?
So for those that were already under sanctions, we have issued letters to those providers indicating that we are going to suspend the sanctions until June 1st. Similar to the CFR deadline, we will revisit that deadline as that approaches. I think we already have several providers that were on withhold that have already complied in the last week. And it's a very small number of providers, but we will look at that again probably in a few weeks and determine whether or not we feel it's appropriate to extend that suspension further.
Thanks, April. Emil, did you want to say something? Did I hear you?
I was just going to say that so we're applying no new actions, as April said, and we've temporarily suspended some of the already in place suspensions, but it is important that those providers that are delinquent from past cycles do work towards getting in a CFR. And I think as many people in the community mental health field know, that we have to conduct a regular test with the federal government called the upper payment limit test. And to the extent that providers do not submit CFRs for these prior periods, the state gets penalized for that, and it limits our ability to adjust reimbursement. So it is critical that providers keep working on that if you were delinquent before this emergency took place, but we're trying to be as reasonable as possible given the circumstances.
Thank you, Emil. Another question. So should waiver requests for LGU deficit funded programs come from the LGU or the provider?
We would, whoever holds the contract, you should initiate the request with them. I think it'd be helpful if you CC OMH so that we're aware of it, but we need to make sure that we coordinate with the LGUs on the flexibility. I think the questions already have asked if OMH would entertain flexibility between instruments, which we're open to. So we think it's going to require coordination with our partners in the counties, which OMH and the counties are prepared to do. Thanks,
Emil. Next question. So there was somewhat of this was discussed in this webinar, and then I know this has been talked about in a variety of other guidance, but there was a question about expanding on treatment plan flexibility. If anyone can speak to that, and if not able to, go ahead, Gary. Yep.
Yeah, so there are some questions that already are in the frequently asked questions on our website that talk about treatment plan flexibility. If the client can't sign, can you take verbal consent, which you can. There's an outstanding question that we're hoping to resolve very shortly, which is about the doctor sign-off and how that can work with telehealth and with with everybody being spread out. Hopefully we'll get an answer to that shortly, but the current FAQs say right now that clinics can manage treatment plan remotely even when the client cannot sign, so they can just take a verbal consent and the provider can document the verbal approval in the client's record. There are other answers about treatment plans as well. So I would suggest that people just keep checking the frequently asked questions, and we will answer them as fast as we can.
Thanks, Gary. So I know we've gotten a couple kind of very similar questions about treatment plan. So I'm just going to refer everybody to that document, and it is on the OMH guidance page. I think we can also chat out to everyone the link to the OMH guidance page where you can find those frequently asked questions. So bear with us a moment. We'll probably chat that out to everybody who's on the webinar just so you can find that immediately if you'd like it. And I know, as Gary said, that's being updated on a regular basis. So I would recommend, I check it on a daily basis, so I would recommend folks check it regularly for updates. Okay, is there a specific time frame for how long funds and telehealth will be allowed?
Did you say funds and telehealth?
Yeah, funding and telehealth.
Well, I think telehealth is separate from whatever is being done with the CFR. So the telehealth telephonic waivers exist to the extent of the emergency declarations declared at this point by the governor. So as long as those are going on, then the telehealth waivers and everything else will be in place, including telephonic. Can't really talk about CFR, Emil, or April.
I think you answered it based on the ability to bill, and I think that that's the answer, right? Don't confuse these other deadlines of CFR extensions, and the state aid discussion.
Thanks, Emil. And we do have another question related to, how soon will folks be hearing about modifiers related to CPT codes? I'm going to take a guess and just say that people should stay tuned to the FAQ. I think we've said that before, but I want to defer to the state, obviously, to give a final answer on that.
No, you're correct. Our goal is to get up a table on our website today, hopefully, that will list for OMH clinic all procedure codes and which specific modifier to use, keeping in mind that other payers outside of Medicaid or Medicaid managed care might require different billing instructions or modifiers or ways of billing telehealth. But this is how the state is requiring that it be done.
Thanks, Gary. So let's see here. Is there any consideration that the state is having right now being given to making up for lost revenue due to lower census?
Is that question relating to residential programs or so if you submit the question and your name, we'll make sure to answer that in the FAQs. If it is a state aid funded program and you're talking about having lower occupancy, in the presentation we talked about how we will waive occupancy standards and funds can be used to deal with this extraordinary challenge. If it is a Medicaid billing program, we believe the 1135 guidance as CMS acts on it and the state is able to give you more billing guidance, that hopefully that will help to mitigate some of this. And then I think we'll all be looking at this challenge of Medicaid revenue and how to solve this. But the next important step in this beyond telehealth is coming out with more 1135 guidance on some of these other programs, which could include apartment treatment and PROs, to offer as much flexibility as we can to bill and preserve revenue.
Thank you, Emil. And we do have the individual's name. And so if the person that chatted that question in wants to clarify, we can include the update as to whether that was for what services that was related to when we send these questions to the state. And that might just help the answer. All right, so next question. Another person chatted in, does OMH know if telephone and telehealth visits are being successful or if providers are facing challenges with this implementation?
This is Emil. I could tell you that I've had conversations with a number of providers, and I've heard providers on some side of the spectrum talk about how they were able to provide continuity of care for upwards of even 90% of their caseload but we have heard providers at the other end of the spectrum that, they're providing care to less than half their caseload. So I think there is variation out there. I think that we're working on more flexibility to, focus for the provider community, focus on continuity of care and preservation of Medicaid. And I think the 1135 is the next big step in that process.
This is Gary. We're also trying to see if there's any kind of training or assistance that we can do through MCTAC or through other means, because for some providers, they've been doing video and telehealth for a while, but for others, this is really a sudden change. So if we can be of help, we would like to be.
Thanks, Gary. And yes, MCTAC has that on their plate. Okay. I'm just scanning the rest of the questions. I know we have about a little less than 10 minutes, so I just want to try and get to some questions that might not be repeated from what we've collected so far. Okay, so this is, I think, related to, this is more related to providing services for children via telehealth. So I think the question is, in addition to the time per contact mentioned earlier, will this also be considered for the clinics? Some children are not comfortable on long phone calls. If broken into smaller times, it might be more helpful.
Yeah, we are looking at it for all services. We're looking at where we have state authority to act on our own and where we need federal authority to comply, to agree with us.
Okay, thank you. Let's see here. Okay, so here's a question. Some providers are using staff to meet with families to distribute and give how to operate equipment for telehealth service for children. Is this time considered part of the service session, or should it be documented as reimbursed expenses?
Could you read the first part again?
Sure. So some providers are using staff to meet with families to distribute and give how-to guides on how to operate equipment for telehealth services for children.
Okay. I think we're going to have to take that question back and look at it.
Okay, all good. Here, let me scan some more of these questions. So this is someone chatting in a question about payment from the county. So our county will not pay us the quarterly advance until they are paid by the state. Thus, the advance due April 1st will be delayed until they verify that they have been paid. Have the counties received funding for the April to June quarter?
Yes, most if not all the counties should have received their April payment by now. There may be a few that don't quite make it, but those should be paid very quickly within the beginning of the new state fiscal year. So I would anticipate there should be no county without a payment by April 10th. It actually will be sooner than that, but that's the requirement. And frankly, I think we've always had the expectation that counties are advancing to providers as we advance to them. So those payments are flowing. The counties are aware. We did make that very clear on the call with the county representatives, which was the last call we just did. But and we can include that in the FAQs.
Great. Thanks, April. I have that down for you, too. Okay, here's another question. Someone is wondering if community agencies that have contracts to provide parent and youth peer support services within the state children's hospitals have the flexibility in the way services are delivered as per the work plan. If the contract is ending and renewals have been submitted, when will the agency hear back regarding the renewal? So there's two questions in there.
I'm sorry, can you say that again, Meg? Sorry.
Yeah, I'll break up the questions. How about that?
Thank you.
Yeah. So someone is wondering if community agencies that have contracts to provide parent and youth peer support services within the state children's hospitals have flexibility in the way the services are delivered as per the work plan. So it looks like they're wondering if community agencies who have contracts to provide parent and youth peer support services within state children's hospitals, do they have the flexibility in the way the services are delivered as per the work plan?
Yeah, that's one I'll have to verify with program staff, but I would assume that if it was already built into the work plan, that it would continue to be an allowable methodology, but let me, we'll shore up that answer for the written FAQs. And what was the second question?
The second part of that was, if the contract is ending and renewals have been submitted, when would the agency hear back regarding the renewal?
So we're still continuing to process contracts and renewals. So I think it depends on the timing of the submission from the provider, where they are in our queue. There's a whole process for us to follow to review contracts and renewals and get them executed. So we are trying to expedite those as we continue to do our work remotely. But my staff are diligently working to. It's hard to say. It's a provider-specific thing. Certainly, providers are welcome to reach out to us more directly to get an exact status on their renewal or their amendments or modifications or contracts in the process. But we are making every effort to keep those things moving. So certainly, I encourage people to reach out for more specifics.
Great. Thank you. So I know we have about 2 minutes left. We do have a set of questions that were kind of repeated. And I just wanted to ask if there were any other questions out there. We've collected all of the questions that have come in. So whether or not we get to address them in the next minute or so, the state will be receiving all of them. And, for those questions that the state was not able to answer, they'll still have them, so they can hopefully provide an update later on in an updated FAQ. But just wanted to give an opportunity, if there's any other questions, to get chatted in, if you could send those our way. Okay, so we do have one question that just got chatted in. Are adults and I believe this person is trying to say child and youth care coordination programs still going to be subject to the 1% net payment reduction?
So that is a Medicaid question, and
got it. Okay.
Yeah, the answer to that is health homes. The 1% does apply for the adult programs, but in the final MRT, I think there's consideration to restore the 1% for kids' health homes.
Okay, but that's a Medicaid question, so that's good. Okay.
Medicaid question, and the final budget hasn't been enacted or put in place yet.
Okay. Okay. Any other questions? I know we're just waiting for folks.
Actually, I have one comment. There was a question early on about minutes for phones, and I just want to point people to two resources. One is many Medicaid managed care plans already purchase phones and minutes for their members, and it will be worth talking to the plans that if you have members who need more minutes, to see if anything could be done there. And also, some of the data companies are providing free data and minutes to people in particular communities, and it'd be worth reaching out to them too.
Thanks, Gary. Yeah. So with that, we are actually right at 1:30. So I just wanted to see Emil, Gary, April, any other of the presenters, if you wanted to share anything else.
Nothing specifically. We appreciate everyone's hard work on all this.
Okay. Well, thank you, everyone. Thanks for your great questions. And like I said, MCTAC is going to work with the state so they get all of the questions. We're recording this, and we will, when the state is ready, share the recording and the slides with you. and hope that, the work continues. And if you need any support, please don't hesitate to reach out. I think that was echoed through all of the OMH partners. But if you have any technical assistance questions, please feel free to email MCTAC as well. So thank you for joining us today.
Thank you.
Take care.
Thank you.